Good morning, everyone. How are you guys
Morning.
today?
Hey, doing very well, thanks.
Today is our third installment of our series on avoiding pitfalls in ABA billing. Let's do a couple quick reintroductions. I'm Matt Zabolotny. I'm the managing principal of exydoc, which is a credentialing software and managed services firm. Heather, why don't you go ahead?
Good morning. I'm Heather Hearn. I'm the Chief Operating Officer of ZMark Health, and I've been in revenue cycle for over 20 years, primarily in behavioral health, but also some physical therapy as well.
And I'm Rayni McMahon. I am the founding principal of Virtue Healthcare Consulting. We work with human services providers from startups to nonprofits in helping streamline operations, any support that folks may need. And I have been in the behavioral health, IDD, and autism space for 27 years now.
Okay, love it. That's great. Well, thank you both for joining me today. I'm going to put up a quick slide here that just shows kind of the three main topics that we've been hitting on here. So if you haven't had a chance to check out the first two sessions, I would definitely recommend it. We have been working to provide some high-level insights based on our experience for ABA providers to help avoid billing problems. All three of our organizations have been seeing a number of ABA clients that have been seeking assistance. We've also seen a lot of BCBAs that may be going into private practice for themselves. And so a few weeks ago, we filmed a session on what it takes to sort of get started in this. And then our second session, which came out maybe a week or so ago, was more centered on the practice management components of running an ABA clinic. And today, we're going to focus a lot of our attention on Heather's favorite topic, which is billing and collections. So, Heather, I'll ask this question. We'll kick it off here. We often hear insurers talk about clean claims. We see some more sophisticated providers kind of managing to a clean claim rate. And that's also a metric that you can sometimes get out of your clearinghouse. What does a clean claim rate mean to you, and how are payers defining that?
So a clean claim is a claim that's free of any issues to prevent rejections, denials. So no inconsistencies on the claim, clear information regarding patient demographics, coverage, data service, location, and then if needed, any medical necessity support. So you want to have your claim that goes out, whether it's on paper or electronic, to be as clean as possible. It needs to be legible. Obviously, if it's written, which most people don't do that anymore, coming out of your EMR, it has to have all the required fields. And then when it gets to the payer, they should process a clean claim within a relatively short period of time. If it's deemed unclean or there's missing information or bad data, then of course you'll run into rejections and denials that will need to have another review and another touch, which will then further delay cash flow.
And I would add to that too, that, I think providers think about just the claim piece, but as Heather said, with the medical necessity pieces of it, that includes everything behind the scenes. So making sure that you have, if it's required, a valid treatment plan in place, that you have progress notes to support the session, and that all of the components on the progress note are present, such as signatures, if you're not using electronic signatures, credentials, that the dates and times on the notes match the claim. So it goes much further than just the billing piece. It actually touches into your clinical team as well.
So I'm hearing that there's a level of sophistication, perhaps at the payer level, that allows them to manage all of the different aspects of this. And basically, if a provider doesn't have all of those various components of the claim aligned, the payers are very good at not paying those claims.
Correct. Or delaying payment.
Or clawing it back.
Clawing it back, right. What are some of the things that, more specifically, a provider can do kind of upstream to prevent claims from denying, or let's say it a different way, to improve their clean claim rate? What are, and I know we touched on it in some of the prior two sessions, but from a sort of a billing transactional standpoint, what are some of the things that you would recommend?
So I would say, and again, we did touch on this in one of our previous webinars, but definitely taking advantage of your EMR and any claim edits that are available. And what's a claim edit? So that is something that you can set up within your EMR to make a hard stop in your EMR so that you can touch it internally to correct it before it goes out to your clearinghouse or to your payer. So any of those claim edits that you're able to set up in your EMR, while they're a pain, you still probably should do them. And Rayni can talk about more details about what specifically some of those are, but setting them up and making sure that you understand what's available in your EMR. Say there's 15, maybe you set up 10 of them. But it's really kind of that internal scrubbing before the claim gets pushed out to your clearinghouse and then pushed out to your payer, just to make sure everything falls in line. Rayni, do you want to talk about specifics?
Sure, absolutely. So, this is one thing that I talk to providers a lot about because they don't even realize that these exist. But making sure that you ask your EHR vendor, if they do have claim edits. And so examples of this could be, it could tie it to a valid treatment plan. So if there is not a current treatment plan in the system, it will stop the claim. If there's not a converted note and it's not signed, it will stop the claim. So it basically does some of the scrubbing that you have to do manually right in the system. The other thing that I would note along the lines of claim edits is that some of the EHR providers are actually starting to use AI and providing whether it's modules or add-ons that will look at this for you. So we'll look to see, is the note there? Is the claim coded correctly? So it's really looking at what are the capabilities of your current EHR and really exploring that. The other thing that I would add to that is, even with the claim edits, is making sure that you have some sort of clinical review process, which also could be through AI with some of the EHR vendors, but making sure that you are understanding the codes, what you can bill under the codes. Coding is a big thing. Understanding what the modifiers mean for that specific payer. We talked about this, I think, in the first session, and it's huge. Modifiers are defined very differently, state by state, payer by payer. So it's really important that your team understand that, because that's the basis of your clean claim.
And some other claim edits, just to piggyback on what Rayni said, you could have your system set up specifically to require a place of service. So if the clinician is doing something and the note is in there and there's no place of service, it can be flagged under a claim edit and it will be held in a bucket that will require some review, but at least you're doing that first prior to sending it to the payer. It could be place of service, it could be a diagnosis code, it could be missing modifiers, it could be bad eligibility, missing specific subscriber information. So really, depending upon how robust your EMR is, you can set all those sort of edits and checks up in the system, like we talked about, as that internal scrubbing prior to sending a claim on.
So if a provider has an EMR that has all of this functionality, which sounds great, how do they manage that? So they have all of these edits that they have set up, maybe in partnership with their vendor, and they've got all of these claims that are their services that are now unable to bill because they've been flagged by all these different claim edits. So how do they sort of proactively manage that so that 35, 40, 50% of their claims aren't getting held up in these buckets? And second question to that is, what's the biggest advantage of turning all of these on? I heard you mention that perhaps it prevents claim denials, but maybe some other advantages. But let's take that first question first on what should they do with those?
So the first thing that I thought of was process, internal process. So if you're starting a new EMR, you're making changes in your EMR, make sure that you're clear with what the options are, the available options, and then get them set up. And then from there, you have to have an internal process, whether it be a team or an individual, depending upon the size of the organization, who monitors these buckets, right? There should be, in the past, there's been reporting that is available to see what is held in your diagnosis bucket, what is held in your place of service bucket. So those will need to be actively monitored and managed, and you'd have to watch for trends very closely. Is it someone at Main Street that continuously forgets to put a place of service? Is it someone at the other location that never puts a subscriber information? So really watching for those errors and monitoring them for trends and then following up very quickly. But it all comes back to process and training to begin with, right? So when you're turning these on, making sure that the entire organization understands what it is and how it will impact the claim, and making sure that's reinforced on a very regular basis. And then, like I said, if you see trends, holding those individuals accountable, which could be additional training, follow-up, making sure that they understand. So that definitely, I think, covers the first part of it. Rayni, do you have anything to add to that?
You're speaking to my BCBA heart when you're talking about data, because it really is about, not only do you have these on to stop things from going out and causing you a lot of pain down the road, but this offers you a great deal of data. So not only what Heather was saying of, is it this person, is it this site, but sometimes it's something within your EHR that isn't turned on as required field or something like that. So it's really looking at that to say, what's the biggest bucket that you have? Where are they falling? And what are the things that you need to change, going back to Heather's process internally, whether it's a manual process that you set up outside of the system, or it's something that you can do within the system that will help you with that.
All right, very good. Rayni, I heard you mention as part of the discussion a moment ago about claim modifiers. And I know this is a topic that you and I have talked about before at length. And give us some examples of perhaps what you see out there that with claim modifiers that causes providers to have issue. And certainly, Heather, you can chime in on it as well. But I know you and I have talked about this before, and I just want to make sure that folks understand exactly what this is and why it's so complicated.
Absolutely. So I can give some great examples for this. I think two of the biggest areas that cause the problems are the HN modifier and the HO. So if you look at it, some Medicaid plans will just define HM is less than a bachelor's degree, HN is a bachelor's degree, and HO is a master's. However, in ABA, it can go very differently depending on the state and depending on the payer. So an example of this is, I've had organizations say, well, we use HN for our RBTs because they have bachelor degrees, and we use HM for our BTs. Some payers, that's not how they see it. They see it as what their role and capacity is. So I have one example where a payer is very specific that HM is any RBT or BT. It doesn't matter on the degree. And HN is only a BC-ABA, or what some states call mid-tiers, which is like a BCBA in training. The other thing that I see a lot of people fall into, and you have to be really careful about this, is the HO modifier. So HO is typically the BCBA. However, in states that have licensure, sometimes it has to be the licensed behavior analyst. So where this hits is when you have somebody that just completed their boards, passed the boards, is a full-blown BCBA. I see places that will say, oh, we're just going to automatically bill them under HO. Well, first, they're not credentialed with the organizations, with the payer organizations yet, and they don't have that licensure status. So it's really important to understand that, because if you bill under that person, first of all, if they're not credentialed, it's going to get denied, but it could also be a huge payback. The other thing that I see is where people will try to kind of work around that and say, well, I have this BCBA here who isn't licensed yet, but I'm going to bill them under this BCBA over here. And very rarely is that something that's allowed for a BCBA. Certainly we bill RBTs and BTs under BCBAs because that's how the system's set up. But very rarely is there a payer that says, oh yeah, sure, bill under that person's license for that. So you have to be really careful and you have to do a lot of research. One other thing that I would add to that is if you ask the payer a question about this, typically they will say to you, we can't tell you how to bill. So you have to be really smart about how you ask it. So for example, if they have HN defined as bachelor or BCBA or BCABA, asking the question, tell me what that means to you. So when you say bachelor level underneath that, what role is that? When you say BCBA in training, how do you define that in this state as this payer? So it's not asking how to bill, but it's asking for the clarification that you need to be able to bill appropriately. So those are the biggest things I would say.
Yes. That's very good. Very good. Heather, we were talking a moment ago about clean claims, and you mentioned clearinghouse. I know that ZMark has come across a couple of clients, customers, if you will, that don't use a clearinghouse. What are some of the advantages of using a clearinghouse as a provider, even a very small, ABA clinic, 1 or 2 BCBAs? What would be an advantage of using that, and how would that help them to improve their claim acceptance by payers?
So I've done both ways. I've worked in organizations that did not use a clearinghouse and kind of was their own internal clearinghouse. And then also now we deal with many different clearinghouses with different clients. So I think there's pros and cons of both, but I would say probably now clearinghouses have evolved and they're much more user friendly. They're filled with data, filled with reports. So I would definitely push anyone, if they had the option or were thinking about it, use a clearinghouse. So we talked about setting up your EMR with all these claim edits or sort of all these catch-alls within the system. Once your claim goes through the claim edits, if you have them turned on, and then it goes to the clearinghouse. So basically you batch in the system, you have a batch and you send it to the clearinghouse. The clearinghouse does another level of review, which is crazy, right? So you've already reviewed them internally. Now it goes to the clearinghouse and they do another level of review. And there are things that will kick out in the clearinghouse that will not go to the payer because there's something wrong. So again, it's another level of scrubbing, another level of review that's very user-friendly. So I would advise anyone to use a clearinghouse because again, you can fix things within the clearinghouse, whatever the issue is, bad subscriber information, whatever eligibility, you can go into the clearinghouse and fix it. And then it will then send to the payer. So then you'll have to go back to your EMR and fix whatever if it was eligibility, but it'll still push out from the clearinghouse to your payer, which again should get you so close to a clean claim at this point because you've had so many levels of review. The other thing that I mentioned briefly is reporting. So we love good reports within your EMR, but a clearinghouse, depending upon which one you use, filled with reports, filled with denial information, rejection information, percentages, clean claim percentage. I mean, you name it. You can trend, you can look at locations, you can look by NPI, you can by payer. So really there's a wealth of knowledge and information within the clearinghouse. So for all those reasons, I think a clearinghouse is a very good option if it's available.
And Heather, I would add to that too, I think they're very user friendly now too. So if you're an organization that might be on an EHR that's not kind of your end game or you're not happy with and doesn't have a lot of reporting or doesn't have claim edits, the clearinghouse is that extra layer of protection. And so it'll tell you what your repairable claims are when you see that. Yes. And I agree with you. There are some that have really incredible reporting that you may not have on the billing side in your EHR. So it's definitely a bonus.
No, we've definitely seen that. Depending upon EMRs, reporting information can be limited. In a specific example, reporting information is limited, but then when you move to the clearinghouse, wealth of information with reporting. So kind of two different systems, but still, I mean, your clearing or your EMR is your main source of information, right? And you could just kind of push your claims through the clearinghouse, but still definitely a ton of reporting capabilities.
And am I correct in saying that some clearinghouse offerings have an eligibility verification component built
Yep.
into them as well?
They do, yes. Now, obviously, you turn it on, you turn it off, it's more money. But yes, there is eligibility included in, I don't want to say all, but many, especially the ones that we're working in today, where you can check eligibility right there real time. So if it goes from your EMR into the clearinghouse, there's something wrong with eligibility, you can click eligibility and it will run it, and that will usually solve what your issue is. Not everybody has that turned on. Not every clearinghouse has that option, but yes, if it's there, again, another thing that should be used.
That's a huge, huge area because insurance can change at the, on a dime. It can change midweek. It can change. There's so many, especially with Medicaid, there's so many different things that can change. And that is a huge issue. If you miss that and you're manually checking eligibility and maybe you only do it once a month, you could have lost 3 weeks of billing right there where you could have had the system that would automatically do it for you.
Yeah, that's very good. Great insights. We've been talking about technology throughout this session here, AI, clearinghouse, all that stuff. One of the things that I know we're also seeing is that providers seem to be switching EMRs at a much more rapid pace than they have, at least in prior years. It seems to us anyway. But what are some of the things that are important considerations as they're switching EMRs? We often see a case where an organization has moved from one EMR to the other, and their cash takes a really big dip after the first 2 or 3 months of them. Now, it often rebounds, but what are some of the things that they can do if, from a billing perspective, billing and collections perspective, if they're planning to migrate from one electronic medical record to another?
So implementation, we're not going to go into that, but obviously the implementation is huge, right? Making sure everything is set up appropriately, all the claim edits, all of the locations, all of the auth requirements and credentialing, all of those things. But when you get to the point where you're implemented and you're ready to bill, yes, we've definitely worked with providers where cash has fallen off the page. Providers who have waited months and months and months to get billing out the door, which is heart attack status. So definitely with that is reports. Through your implementation, understand what reports are available. And if you have an internal team of report writers, that's great. They can also write some reports for you. But I would definitely watch trends, especially when it comes to unbilled services. There's got to be some report that's available that can show you what is still stuck in your system for whatever reason. Then you can see, is it a specific payer? Is it a specific location, clinician? I mean, really, I would definitely watch reports, watch unbilled, because that didn't go anywhere. It can't even get to the payer for them to respond. And then definitely watch your rejections and denials. Like we said, watch the clearinghouse, see if anything kicks out in there, and then watch any denials and rejections that are coming back from the payer. I'm big on trends. Typically, that can help you diagnose some of your issues. So if you're constantly seeing the same location, there's probably something wrong with that location, whether it's not contracted or the payer is not recognizing the location. But definitely watching reports and trends. I feel like that's an easy way to help guide next steps.
And I think when you're going through the implementation or even just going through the demo process, understanding how that data flow from one system goes to the other. Some systems are better than that at others. And depending if you have an old legacy system, pulling the data out of that might be a little bit harder than if you have something that's newer. And I think that really being prepared that if you move from a system that doesn't have claim edits to one that does have claim edits, you're going to see a lot of things that maybe weren't visible before. So there might be a lot of stuff in that unbilled bucket, understanding that it's a little bit of pain up front, but that it will eventually help you down the road, because that means you're sending out a bunch of unclean claims prior to this that if you have an audit could be a problem. So although it's painful, see the claim edit piece as a gift for the future to make sure that you're doing the right things.
Heather, when you talked about monitoring some of the trends, what specifically would you be looking at during this transition to make sure data is kind of staying where it's supposed to from 1 month to the next as companies transition?
Well, I would typically get your last report from your EMR. If you're transitioning EMRs, get a report to understand sort of where you were, what your collection rates look like, your DSO, what your denial rates looked like. And then I would go into the new system and I would be comparing the two, right? So there's going to be delays when you move into a new system because you probably won't be able to bill right away because everything you thought was set up probably isn't. So you need to go back and fix that. So I would compare where it was versus where it is today to see if is there a revenue drop? Is it because all the charges aren't in? Or the contracted rates in the system? Or are they all distributing at zero for some reason? So definitely kind of where you were versus where you are in the first couple of months, I think will give you a good roadmap. And then as you get moving in your new EMR or in your new software, you'd be able to kind of come up with a new baseline. How much cash are you getting in? Did you typically collect $10,000 a month from all of your payers? And now all of a sudden it's 1,000. And then you could also then dig into there further. Is it more specific to one payer, one location, one clinician? So definitely, like I said before, trending. But if you're moving from one EMR to another, I would get a foundational report, a baseline of where you were versus where you need to be over the next couple months in a new software.
Should organizations that are making this migration consider any kind of supplemental staffing, especially on the billing side, to get them through what would be all of these added volumes, right? Because these teams are still trying to run out all the stuff in their old system while learning the new system and getting all that up and running. And you've seen providers doing that, correct?
Yes.
Yeah.
Yes.
Good.
Yes, for sure. And another thing to consider, and again, we're talking specifically if you leave one EMR and move into another versus starting a brand new one. A lot of the stuff is still the same, but if you're leaving one and moving to the other, one main thing that people tend to forget is who is going to work the old system versus the new system, right? Because when you move into the new system, you've gone through months and months and months of implementation meetings, you're ready to go, or maybe not, but you're in your new system. And all eyes are typically focused over here because it's new. You want to make sure you're watching for those trends. Everything's happening as it should. Somebody has to wind down the AR from your old system. So we've helped providers do that because it's hard managing two systems. And for months and months, you're going to have to manage two systems because you want to wind down your old AR and get everything you possibly can while focusing on your new software, your new system. So that can be a bit overwhelming for a lot of providers. So we have helped. We've helped wind down AR. We've helped make sure all the billing gets out of the old system and paid as it should have, or rebuild if needed. And then we've also helped providers in the current system too, watch for those trends, watch for reporting, help to diagnose what issues are. So we've worked on both ends, but a lot of providers tend to forget about the old system once they're in the new. And there could be a lot of money there, right? I mean, because again, it depends on what your denials look like. So making sure you're watching both is important, and we've helped providers with both.
Heather, you made me think of another thing too, is as you're planning to move from one system to the other, making sure that you're planning for the timing of getting your ERAs into the new, like going through the process to get your ERAs into the new system. I see that a lot of times where, you know, you're so focused on getting the EMR in place that you're not thinking about that. So you still have ERAs going into the old system versus so that is a big thing of that time because it does take time to do that.
It does.
So
yes, definitely.
I'm going to ask you guys one final question. This is more philosophical, but I think you've both gone through EMR conversions probably more than once. You've worked with customers who have gone through EMR conversions. Do you see? Well, so we're gonna categorize everybody into two groups. One group is practitioner or providers who have adjusted their internal processes to meet the to maximize the EMR, and the other group is providers who have tried to modify and manipulate and change the EMR to meet their processes, right? So we've got two groups, and we see them both, right? We see organizations that, hey, we're going to change the way we're doing things to maximize our EMR, and we have other groups that are they don't want to change their processes. They'd rather modify the electronic medical record to try to meet their internal processes. Which of those two groups do you guys think is more successful in the long run with a new EMR?
1000%. Making sure that you use your new EMR and adjust your process internally to maximize all of the benefits in your new EMR. I've worked with providers where that does not happen. They move into a new EMR and they're still pulling all of the same behavior from their old EMR.
Yeah.
And then what happens is the new EMR gets overly customized, and it's costly to customize, right? But we don't like this, and this doesn't work. And so customize. And then before you know it, it is a totally different EMR than what you purchased. And that can be good and bad, right? Because when you overly customize things, then you can't take updates as like a regular customer. I've worked in different organizations where we couldn't take an update because it would break the entire system because we were too customized. So if possible, you should work within the parameters of the EMR and adjust your internal process as you can. Now, there might be some things that you need to tweak here and there, but overwhelmingly, you should work within the parameters of your EMR. At least that's my opinion, Rayni.
Well, we were both smiling because we clearly share the same opinion. Yeah, I mean, I think we've been in situations, especially when EMRs were just first coming into the scene, like when the meaningful use was coming through. I think everybody got really excited and they're like, we're going to customize this. And I think over customization is the devil when it comes to EHRs. You know, it's one of those things where you think it's going to make it easier to work within your system, but then you end up with 10 different reports that kind of show the same thing, but nobody knows which one to use. And this center over here uses this one. And it gets to the point where it actually works against you rather than for you. And it's not saying that you have to completely change everything that you do in a major way, but you really do have to look at how the EHR integrates into your day-to-day processes and operations. Because if you're constantly battling that and your processes don't work at all with, it's never going to work for you. And then you see organizations saying this EMR is horrible, it's awful, and that's why they change to another one. But then they see you're still going to have those same problems no matter which path you go. So it definitely, you can customize, like you said, to a bit. There's some things that are important for providers, like a specific report or something, but making sure that you're really thoughtful about it and making sure that you understand that there's a line that can make it much more difficult for you.
That was a great question. I'm glad we decided to ask that one, but I've seen it countless times as well. I'll just add that the concept of we're gonna ditch this current vendor because it hasn't worked, and we're going to go to this one just to repeat the exact same behaviors is it's commonplace. We see it a lot, and I think that's a great way to end this third session. Now, we have touched on these issues at a very, very high level. All of this can be dug into with a lot more, with a lot more intent and find a lot more. There's so much out there, but I think what we touched on were some of the really high level points. What I'll do is leave us with a quick just a slide that shows everyone's contact info. I really appreciate you guys joining. I think there's a ton of information out here. Contact information is on the screen. I know all of us would love to chat on any of these topics further. I know when we started this endeavor, we had to keep it sort of focused, or this would be a 17-year series of sessions on this stuff, because it's a lot of detail, a lot of content. But I think you guys did a great job on hitting any of these. And based on feedback we get from our customers, maybe we'll do some more down the road with different topics, maybe diving in more. This was a lot of fun. So I want to thank you both very much. Appreciate everything you do. And again, feel free to reach out to any of us at any time if anybody has questions. Okay.
Thank you.
Thank
Thanks
you.
so much.